at this sort of hearing. I'm hoping next week that we'll have some language we'll bring before the committee. So I'm going to high level. COVID has been pretty much all we've been working on since the middle of March, and the model was finally released. Some of us have had previews of it, but I wanted to get an update because some really big decisions are being made based on that model, and having some understanding of underlying assumptions and why specific choices were made, I think would be helpful. But I do want to start with Dr. Chris Erzman, the epidemiologist. We actually got to know each other through vaccine conversations, and then a little bit more as she managed the measles outbreak in Minneapolis. And since the very beginning, she has been watching COVID. And so I'd like her to talk, and I'm going to ask everybody to mute unless you're speaking. And for communication purposes, Ms. Strand is monitoring, and if you raise your hand, she'll put you on a list. You can also chat directly with her, and then I will recognize you and have you ask questions. So I'm going to ask you to ask questions after Ms. Erzman, and then again after Mr. Gildemeister. So Dr. Erzman, thank you very much. If you could give us an overview, a little bit of where we started with COVID, maybe where we're at, and then I do have some questions that you are, I think, uniquely suited to help us answer.
Thank you so much. Well, you know, so just to, I guess, restate who I am. I'm Chris Erzman. I'm the Director for Infectious Disease here at the Minnesota Department of Health, and I appreciate the chance to talk with you today. I was given some questions that I was hoping was what you wanted to hear a little bit about. I think you're aware, though, of our numbers. I'll just make sure you have the update. Today we're at 1,912 cases. Unfortunately, we had 7 more deaths for a total of 94 deaths, and we have 213 hospitalizations right now with 103 individuals who are in ICU. And we have 117 long-term care or congregate care facilities that currently have outbreaks. Although I do want to point out, as Commissioner Malcolm mentioned in the media briefing yesterday, that we have some facilities that have a number of cases, but I want to acknowledge that at least half of our facilities only have a single case. So we know that infection prevention and control is making a difference. So I do want to acknowledge that. So the questions, so what I was going to do is answer some questions that I was given, and they sort of follow a flow to talk about the coronavirus, just testing, tracking, quarantine and isolation, herd immunity, serologic testing, just kind of going through some of those things. So I'll start with that and then go from there. So one of the questions that I was asked was just, does the corona family of viruses have a pattern related to seasonality? And so although some of the diseases caused by coronavirus, like the common cold, are seasonal, we can't really predict the behavior of a novel virus based on how some of the other viruses act. So we can't be sure that what we see with other viruses in the coronavirus family will be predictive of what we'll see with the SARS-CoV-2, which is the name we have for the coronavirus. So just for that question, we do know that obviously in warmer weather, people are outside more, you're not close together. You know, there's some research that says our immune systems are happier in the summer than they are in the winter because of vitamin D and light exposure. So lots of different things. But at this point, I would say that we don't want to make any predictions about whether or not we'll see a seasonality with this coronavirus. The next topic was just the governor has asked for resources for testing, tracking, tracing, quarantine, and isolation. Please tell us about what is currently happening and what changes he's proposing. So Right now, the Minnesota Department of Health receives information on all of the laboratory testing for COVID-19 done on Minnesota residents, both the negative and positive results. We follow up on all positive results. The individual with the positive result is contacted within 24 hours of receipt of the result. We conduct a case investigation, which includes learning more about the individual's disease, their onset of symptoms, the type of symptoms they're having, and potential contacts. We ask about contacts beginning 48 hours before the individual's symptoms started to account for the possibility of asymptomatic transmission. And we reach out to all contacts within 24 hours to discuss their exposure and what it means for quarantine. We have teams that are working 7 days a week, 12 hours a day. The governor has been talking about the need to make sure that testing is widely available. And this is not really any different than, so when he talks about we want to make testing more widely available so that we can test, track, trace, quarantine, and isolate, it's really not any different than what we've been doing all along. It just represents a commitment to making sure that Minnesotans have the needed, that need to be tested, have that opportunity. There's a public-private team work group that's discussing this issue to identify any potential roadblocks to testing. And as more testing is done, we will expand our capacity so that we can continue to follow up with cases and contacts within 24 hours as we've been doing. Another question that I was asked was, what is herd immunity and sort of how do we get to herd immunity? And I think I've talked about this before with this group, but when most of the population is immune to an infectious disease, this provides indirect protection or herd immunity to those who are not immune to the disease. So if 80% of the population is immune to a virus, 4 out of every 5 people who encounter someone with the disease won't get sick and won't spread the disease any further. And so in this way, you can keep the spread of an infectious disease under control. And susceptible and vulnerable populations are less likely to be exposed. So really with herd immunity, you're trying to reduce the likelihood that someone who's infectious comes in contact with a susceptible person. And depending on how contagious an infection is, usually 70 to 90% of a population needs immunity to achieve this herd immunity. For measles, we want well over 90%, about 95% herd immunity. And even then, as we saw in 2017, we can have outbreaks if there are pockets of unvaccinated individuals. So how do we get to this? Well, we can get our immunity in several different ways. With active immunity, you actually produce antibodies in response to the antigen, and you can have this, naturally you get the disease or artificially because you've been vaccinated. And this type of immunity tends to be more long-term. There's also passive immunity where you receive antibodies produced by someone else. And this can be natural from mother to baby or passive with immune globulin, and that tends to be much more short-term. And we've really talked about kind of both of these types of immunity as we thought about COVID, because we've certainly, there have been some conversations about could individuals who've recovered, could their antibodies be used to help provide protection for someone else? So we can achieve this herd immunity in 2 ways, either because the population's had the disease and develops antibody, or through vaccination. And I'm just going to say just a couple things about vaccination because it's not something that's going to be available in the short term. So vaccination against COVID-19 is unlikely to be available for a number of months because even in an expedited situation, there are a number of important steps that must be met. There are 3 phases of clinical trials for a vaccine. In phase 1, a vaccine is given to healthy volunteers to test if it's safe and induce an immune response. And then they go on and there's phase 2, 2A, 2B, 3, and all of that takes time. Right now, there are a number of vaccine candidates that are out there and being evaluated. 56 of these, or 72%, are being developed by private industry, and 22 or 28% are projects that are led by academic or public sector organizations. Of all the active vaccine candidates, 36 or 40, 36 is the number, and 46% of the developers are in North America. 14 or 18% are in China. 14 or another 18% are in Asia, excluding China, and then another 14 or 18% are in Europe. So we've got vaccine development happening across multiple countries, and the countries in which this is happening, it represents about 3/4 of the global population. But I just want to acknowledge that a COVID vaccine is not likely, will not be widely available to the public until sometime in 2021, most likely. So the question is, what do we do in the meantime? And this is why serologic testing is really of such great interest. And so what are we talking about when we talk about serologic testing? Well, when I just explained about the follow-up that we're doing with cases, that is based on molecular testing, PCR testing. So molecular tests currently used to detect COVID-19 by state public health laboratories, health system laboratories, and licensed commercial laboratories are these polymerase chain reaction tests, or PCR testing. And this is not serology. And the FDA-approved PCR testing is the most accurate testing currently available. These tests use a sample that's collected from a patient's nose or throat with a swab. So that's the testing that we're currently doing right now to identify cases. But serology tests that you've heard a lot about, they're also called antibody tests, are used to determine who has had COVID-19. This test could be helpful for people who didn't have symptoms or had very mild symptoms to determine if they have been infected. Serology testing, rather than a swab that's collected from a patient's nose or throat, uses a blood sample and can detect that an individual's body has developed antibodies against a particular virus. And if antibodies are detected, it indicates that the person has been infected with the virus in the past and may have some protection against the virus if they're exposed again. So serologic tests are valuable in that they can help us track the spread of disease, but they're not reliable for diagnostic purposes, determining if someone has COVID-19 right now, and they're not approved for such use. And I do want to be clear that if someone has a negative serologic test, that does not mean that they don't have COVID. It just means that the timing at that moment, they don't have antibodies. Because we're interested in knowing what proportion of the population has some level of immunity to COVID-19 beyond just those individuals who tested positive with the PCR test, serologic or antibody tests are of great interest and obviously have been discussed quite a lot. But I want to mention a number of caveats and considerations as we think about serologic testing. First of all, we do not know what the correlates of protection are for COVID-19. And what that means is, what antibody level does a person actually have to provide immunity and future protection? So that's one thing that we don't know. And some tests don't provide us with a quantitative or number response. It's just sort of a, yes, you have antibodies, or no, you don't. So one thing that's going to be really important as we move forward in understanding COVID-19 is, okay, what is a correlate of protection for someone who's been exposed, who's had the infection? What level of antibody do we need to see? And then the other question that we don't have good answers for at this time is, what is the duration of protection? For some diseases like measles, protection is lifelong, but for other diseases, protection is more limited. So that's another question that needs to be answered as we're looking at use of serologic tests. Now, right now, the FDA has only approved one COVID-19 serology test in the United States. There are a number of tests that are currently on the market that have not been FDA approved, and we really don't know how well these tests work. One of the concerns is that the test may not be specific to COVID-19 or the virus that causes COVID-19. There are many types of coronavirus, as we acknowledged, and I think you may have heard that, a third of the cases of common cold may have been caused by coronavirus. So if you have a test that isn't specific to SARS-CoV-2, the specific virus that causes COVID-19, you may be detecting antibodies to a coronavirus, but not the one you want, rather one that causes a cold. So it's really important that the tests that are being used, are FDA approved, and that you fully understand what that test is testing for. It's also another consideration with that is that you could have a positive serologic test result, meaning that you have been infected, and still shed the virus. So it's not necessarily always a perfect answer. And negative results don't necessarily rule out that you aren't infected. So it's just important that we know the limitations of this tool. It's a great tool, but we need to know, first of all, what we don't know yet about serology testing, and then that when you're using some of these non-FDA approved tests, there can be real challenges with that. One of the things that we've seen and that we're concerned about is that there have been some of these tests used, and people are getting, a piece of paper that says, you're negative and now you don't have to social distance anymore. And that's not accurate, and that can be problematic. So that's an important consideration. One of the other things that I was asked was, well, if MDH is coordinating serologic testing, how is all this going to work? At this point, our goal right now, with both within our own system and then as participants on the governor's work group looking at laboratory testing, our goal is to make sure that first of all, we're getting the molecular or PCR test as available as possible and as available in as many parts of the state as possible. But then in addition to that, this work group is also focusing on what is appropriate serologic testing that could be used in Minnesota, and how could that be implemented. And as I talked about, and as it relates to this question of herd immunity, seroprevalence studies or serologic testing will help give us insight into the proportion of the population that's been exposed to COVID-19. But as I said, understanding exactly how long the protective immunity, what is protective immunity and how long it might last is going to need a bit more research. And ultimately, our goal is having a vaccine that produces protective and long-lasting immunity, and that will hopefully be the way that we can establish, strong herd immunity across Minnesota. So I tried to sort of tie the questions together and hopefully made a little bit of a logical progression, but I'm happy to answer questions if people have them.
And members, we have a few more minutes with Ms. Earsman, and I want to thank you. I generated that list because I feel like we and a lot of other people have you as an expert available to us to talk about some things that are going to be really important in forming judgments going forward about where we invest in testing and what goals we might have. So as we get ready to open up the economy, what herd immunity isn't a definite point in time. It's a softer definition, but it's something that we need to work towards, be it through a vaccine or this natural contact. And so I want to thank you. So members, if you want to raise your hand or message Bailey if you have questions for Ms. Earsman. So in the serologic testing, how will we, or when will we know if somebody has this natural antibody, if they've been exposed, if they have naturally occurring antibodies, how will we know how long they're protected? Or is it just a matter of waiting until till the virus comes back around? Ms. Ersman, you're on mute. Can we unmute Chris?
Okay. All right,
There you
thank
go.
you. Yeah, I was trying to unmute and it kept saying the host has muted you. So at any
Sorry.
rate, no, that's fine. Well, I think, even as we're having these conversations, there are multiple, people are looking at this in multiple different places. So there should be more and more information, just as we've learned. When I think about this, it was January 17th that I was looking at my calendar. We had a conference call with CDC about coronavirus. And here we are, and it's not even April 17th, and there's so much that we've learned. So there's ongoing research and looking at all of these different things, including the serology. So we'll continue to be monitoring to see, okay, what level is protective and, how long does it last. I think, though, that, even if the immunity is short term, if we can have some level of protection until a vaccine's available, that would be excellent as well. But yeah, I think when I think about what we've learned in the 3 months since January 17th, I think there'll be a lot more information that will help us make good decisions coming in the near future.
Very good. Thank you. And Senator Abler, I see your hand is up. Senator Abler, your question? We need you to unmute, Senator Abler. Bailey, can you unmute Senator Abler?
Am I unmuted?
Now you're
Yeah.
unmuted. Thank you.
Okay. So I was actually driving. I just had to pull over. So we want to be safe, and it'd be bad to have a crash because of this. Would that be COVID related? Maybe that's just a joke. I have
And not a good
questions.
one.
Sorry. Two questions. One is the one's just two small parts. Thinking about how you are the group that decides what to open or not. Is there kind of a COVID risk index that you sort of think about different kinds of places when you consider what might open or not going forward here?
Oh,
Ms. Ersman?
yeah, certainly. I think, the governor's looking at those situations in which people are, in more crowded settings. And I know that some of the things that they're talking about are how can various businesses and industries open in a manner that allows them to be functioning again, but still is protecting the workforce and things like that, so that social distancing, all of those kinds of things. So
right.
Yeah, all those things are being taken into account.
Okay, and I've got a B part to that question and then a short next one. So just like the car washes are closed. I have an automatic car wash that's closed. Can you just help me understand the rationale of having places like that closed? Because I think that would have an index of about 0 because it's all automatic.
Ms. Ersman?
Yeah, Senator Abler, that's an excellent question, and I'll be honest, I wasn't part of the details of automatic car washes. Okay. But yes, when you describe that, and I'm thinking of the ones that I've worked through where you put your credit card up and then you just go in and you sit in your car. Yeah, that's a good question, and I don't have a good answer for you.
I'll understand that. Can you comment about something else? There's really interesting alternative treatments that are coming up. There's some doctors in Michigan working with nebulizing hydrogen peroxide and iodine and all that. Do you see, are you familiar with, is there a promise in some of that you see also as hope for treatment?
I can't comment on, oh, I'm sorry, Senator Benson, okay. Senator Abler. I can't comment on that. I would say that being from the Minnesota Department of Health, that our recommendations would be both tied to what CDC has reviewed as well as what's FDA approved. And we want to make sure we're evidence-based, but if those treatments had those criteria, we would be very much interested in that.
Thank you.
Thank
And
you.
Madam Chair, I told you I'd be brief.
Senator
Thank you very
Abel,
much.
Thank you. Thank you. Next, Senator Nelson, then Senator Matthews. Senator Nelson, we have you on mute. And Senator Matthews, you might want to take yourself off mute just so we're ready to go. All right, I see Senator Matthews. Senator Nelson, please proceed. And it sounds like Senator Nelson maybe is having a little trouble. Let's go to Senator Matthews and then we'll go back to Senator Nelson.
All right, now can you hear me?
Thank you, Senator Matthews. Yes.
Excellent. Thank you, Madam Chair. Doctor, thank you for your comments. Do you have any more information on the breakdown when you gave early on about numbers that are hospitalized, the current cases we're seeing right now? What's the breakdown out in rural hospitals outside of the metro area? I come from a district that represents the Princeton Hospital. Are there cases out in rural Minnesota that have few or no current COVID cases they're caring for, or what's the breakdown across Minnesota?
Senator Matthews, I don't have the breakdown of hospitalizations by Metro versus Greater Minnesota, but I can get that for you. So let me follow up with our data team and we will pull out the 7-county metro and let you know what the difference is in terms of hospitalization.
I appreciate that. Thank you.
And Senator Nelson, you remain on the list. Thank you, Senator Matthews. Senator Nelson, please proceed.
Hello. Thank you very much, Madam Chair and Ms. Erzman for the update today. I'm wondering if you could just kind of help as we are thinking about, in my mind, I kind of see us moving into phase 2, but clearly I'd like you to comment on this. What I would hope that with the new testing options, the serologic testing, the antibody testing, and combined with COVID testing, I think you call that the PCR testing. Can we get to that point where those type of testing things will allow us to move into a phase 2 in which we start to reopen Minnesota and we begin protecting those who are most vulnerable, or those, if this is still the case, that it's typically our elderly and those with underlying medical conditions. So in other words, we kind of shift focus from trying to protect the whole, in our case, the whole state from exposure to COVID. We shift to protecting those who are most likely to not only get the COVID-19 infection, but have serious consequences. So I'm wondering if you can speak a little bit to that.
Ms. Erzman?
Thank you, Senator Benson and Senator Nelson. Yeah, that's actually a really good point. You know, part of the goal with the current time that's being spent, I guess, sheltering in place is to make sure that our healthcare systems are ready to respond. And so, you know, we want to make sure that that has happened. And that's sort of separate from the testing that we're doing, but we want to make sure that our healthcare systems are prepared so that, you know, as we kind of reopen society, that we're prepared to deal with additional cases should that happen. But I think the idea that you're talking about of kind of focusing on, you know, those individuals who have the highest complications is a very reasonable one. And when we look at the data, and I'm just trying to, I've got so many pages of data here. I'm just trying to look and grab. But when we look at our data, I mean, we can see that the majority of our severe cases, hospitalizations, and deaths are happening in our elderly and in populations with underlying health conditions. So I think that that's very reasonable. Here, in terms of our cases, 96% of our cases have an underlying health condition. 80% of the individuals who are in intensive care have an underlying health condition, and 78% of our hospitalized cases have underlying health conditions. And then when we look at, deaths, our median age for death is 87. So we do know that there are certain populations that are at greatest risk. And so, as we have taken the time to make sure healthcare is stood up and then can look at ways that we can reopen things in a gradual manner with still, offering social distancing, I think, we will see that we can start to open things up.
Thank you. And
Senator Nelson, anything
Madam
further?
Chair,
And I have Senator Wiklund, Senator Rosen, and then Kiffmeyer. So quite a few questions. Senator Nelson, wrapping up.
Oh, thank you. I couldn't tell here from not seeing all the hands. I just wanted to again thank Ms. Erzman for bringing this discussion forward. I don't see testing as being optional, and I just don't know that we just can't have that economic recovery, much less a fast one, without this widespread testing that we've discussed today. And it will be it's a good investment for our state. And we know that testing Minnesotans will be one of the best ways we can get people back to work and school, getting kids back to school and quickly. And so I wanted to ask on the timing. I'm concerned. It seems to me that we must begin this testing quickly. And the more quickly that we begin testing, the more we will be able to return to what we sense as a more normal Minnesota. We'll be able to open more businesses safely. We'll be able to target our resources in protecting those who are most at risk. And the longer we wait, I think it will be harder to capture all the impacts of the testing. And I'm wondering if you can speak a little bit to the timing of when we can and should start a greater testing, both for the virus itself and most importantly, this antibody testing.
There is. I'm sorry.
No, that's okay.
Senator Benson. When I'm sitting in my office, I forget all the protocol. So yeah, Senator Benson, Senator Nelson. There, as I mentioned earlier, the governor has a public-private work group that's looking at testing, and so they are discussing all these things. It includes multiple individuals, including clinical staff, laboratorians from all the health systems. And so we're working together to talk about, okay, how are we going to make sure that testing becomes more and more available? One of the challenges is that the system for testing, there's multiple elements across the system, and each of those elements has the potential to have kind of a problem with logistics. So first it's like, do we have the reagents that you need? And then the question is, do you have the swabs that you need to test people? And then do you have the staff and the personal protective equipment so that they can do the testing safely? And so we're working on this team to make sure that we are opening up testing to all the Minnesotans who need it. And so that team is working. We have a logistics manager now who is looking at how we can make sure that all the systems can get the supplies that they need. So that is an ongoing active process. We have a meeting tonight at 6 o'clock. So that's continuing to happen.
Oh, thank you. I have a few more questions, but I'll take them offline or at the end of today's hearing if there's time. Thank you so much.
Thank you. Senator Wiklund, then Rosen, Kiffmeyer, Jensen. Senator Wiklund. and you'll need to unmute yourself. There you go. Thank you.
Thank you, Senator Benson. I just was curious, a couple of things. You had mentioned the plan that's going on to plan for testing. Do you have any sense for a timeline for coming up with a statewide plan? And then secondly, when you talked about underlying conditions and how many of the patients have underlying conditions, is there any sense of whether those underlying conditions have more or less control or are impacted by those underlying conditions? Like, for example, diabetes is one of them, I think. Is that something where you can tell if people are more affected if they're not in good control of their chronic condition, or is there any assessment of that yet?
Ms. Earsman, sorry.
It's okay. Senator Benson, Senator Wicklund. Yes, we're working on kind of establishing the plan. And I think maybe a better way to frame this is, not that we're going to do statewide testing, but that we're going to make sure that everyone who needs to be tested has that opportunity. We have a priority list of individuals who need to be tested. And what we realize is that even having prioritized, some of the folks on that list we can't even get to. So our goal is to make sure that everyone that needs to be tested can be, and we're going to start with that priority list. And as I said, that this team is actively discussing that, and we have a meeting tonight at 6. And then in terms of, underlying health conditions, yes, certainly just having an underlying health condition is a factor, but if those conditions are not under control, that puts a person at greater risk. And we currently have a team that is reviewing hospitalizations in great detail. So, I'm giving you information now, just how many people are hospitalized and some broad things. This team is actually doing chart reviews to be able to get more information, so we'll have a more complete picture.
Thank you, Ms. Earsman. Senator Wicklund, any further questions? Okay, thank you. Next on my list, Senator Rosen, then Kiffmeyer Jensen. Senator Rosen.
Okay, thank you, Madam Chair. Thank you very much, Doctor, for this information. I look back at when we've had the first hearing about this issue very, very long ago, and all the information that we now have acquired from this. I serve a district in southern Minnesota that's been heavily hit. One county, Martin County, has 39 cases. They are now, let's see, they have got 39 cases, 31 recoveries, and only 4 active cases. And they had, I believe, 4 deaths. And it was strictly in this county. And I think we underestimate the ability of our local communities, our local public health, and all the above to really take an issue such as COVID-19 and do what's right. And you look at the map that I pulled up that you have about all the cases through the state. And of course, the larger populations have them. St. Louis County is a bright blue, and the Twin Cities and Olmsted County. And then there's Martin County, this 20,000 population, has all these cases. And they can track exactly where it went to, what church it was. But they have been able to contain that because of their active arrangements, communications, coordination with law enforcement, with the hospitals, with the providers in the area and their public health. And it's been very, very impressive. You could imagine how that could explode in southern and southwestern Minnesota because of some 39 cases. That's a lot for a little community, but they were able to contain it. So I just really want to stress the fact that we have underestimated the ability for the local officials to step up and really take care of what we need to do to move forward. And we've learned so much. This was a very informative hearing. We're constantly learning, but it's also, there's some very good coordination in place. And it's more just a statement, Madam Chair.
Excellent. Thank you, Senator Rosen. Senator Kiffmeyer. Senator Kiffmeyer, and Senator Jensen, you're on deck.
Okay, I can speak now. Thank you. You can't unmute yourself, so you have to kind of wait. At any
Okay.
rate, thank you, Ms. Erzman. We're really glad to have this informative kind of discussion. I have a few questions, though, having to do with the tests when they are ready. And I'm going to kind of read through them a little bit, and then maybe you can comment. One of them is, I know there's been talk of testing the vulnerable, but more than likely, we're going to probably continue to quarantine them at any rate. I think the bigger concern has come with the staff who are taking care of them. It would be very helpful to know in regards to that particular population, since that's the high risk, targeted, and a lot of deaths have come from that. But to test those employees. The other one is healthcare workers that are on the front lines, such as an ICU or direct patient care with COVID patients. The critical sectors as well. I think people are very much, those who are going to work and are in a situation where they may need that. One of the questions I have for you as well is, have there been some consideration for maybe doing an entire population in a particular congregate nursing home, and to just see if you can extrapolate from that what percent are immune, what percent are not, and get an idea with that. And do the same thing, some sampling and extrapolations in rural, in some counties like Senator Rosen's, maybe the metro and the suburbs as well, to do kind of a test group. It's not exactly a clinical trial or anything that serious, but it would at least give you more than just taking care of a particular group in one area, and then you don't kind of have an idea, well, what about other spots? At any rate, if you could just respond to those, and I'll just listen.
Ms. Erzman?
Senator Benson and Senator Kiffmeyer, actually, that's an excellent point you make. I do want to reiterate that when we've prioritized testing, and this is now testing looking for cases of disease right now, so the molecular tests, we have prioritized both staff and healthcare workers. So our highest priority is congregate care settings and congregate living, and it's both the residents or guests as well as the staff and healthcare workers. And that because we recognize that that's very important. We know that our congregate care settings have done a really good job of limiting visitors and kind of locking down. So we know that the staff and healthcare workers are an important part of how things may be transmitted. So that is, they are part of our highest priority as our healthcare workers. So once we talk about our congregate care settings, then next is hospitalized patients and then healthcare workers. And the reason for congregate care is because they're most vulnerable, and we want to make sure that we're getting in there right away to intervene. For hospitalized patients, it's because that test makes a difference in their care. Either it makes them eligible to be part of clinical trials if they're positive, and it can help inform whether or not they need to have a special negative air pressure room, that type of thing. So yes, but that's very true. Those are very important folks that need to be tested. Then when you're talking about sampling of the population, yes, actually that is something that we would be looking at doing going forward, using that serology test that would look at whether or not someone has been exposed and infected in the past. And we've done this before. Back in my early days at the department, we worked with the Red Cross to do a seroprevalence study looking at measles immunity, and found that at that time, 90% of the adult blood donating population was immune to measles. And we could do similar things. Those would be things we would be looking at to use the serology testing for, to look at the population and say, okay, what are we seeing? The only challenge there is we want to make sure, one, that we have a valid and reliable test, and that we're using it in the right manner. But those are things that, yes, we'll be looking at moving forward.
Thank you. Anything further? I see Senator Kiffmeyer has herself muted. Senator Jensen.
I'm good, thank you.
Thank you. Senator Jensen.
Thank you, Madam Chair. Can you hear me okay?
Yes, thank you. Proceed.
Thank you. And thank you, Ms. Erisman, for being here today. I'm trying to understand, in the context of the numbers we're seeing, and Senator Gazelka shared numbers today on the Senate floor, I was wondering if you'd be willing to help me understand why it seems so important to push this surge 4 to 6 weeks down the line. And I guess I have another question is, on the data that we receive routinely from the Minnesota update, is there a way that on the dashboard, that sort of nifty little dashboard, is there a way that we could maybe put in something like number of suicides, number of abuse hotline phone calls and things like that? Because I think we're sort of ignoring that mind, body, spirit piece. We're just focusing on the body. And I think the mind and the spirit, those numbers don't calculate as readily, but they're just as real. So I guess it's a two question. One is, give me 3 bullet points so I can tell both the Democrats and the Republicans in my district why it is that we seem so hell-bent on pushing that surge down 4 to 6 weeks. And then can we add to that dashboard so that we're seeing a bigger picture? Thank you.
And Ms. Erisman, to the extent you can answer Senator Jensen's questions, some of those might be Mr. Gildemeister questions, and we can revisit those. So Ms. Erisman.
Thank you, Senator Benson and Senator Jensen. Yes, I think that when you're talking about pushing that 4 to 6 weeks, that's based on some of the modeling that's been done. I'll just comment on the fact that our goal in having the shelter in place is to really slow down the spread. Excuse me, I gotta get a drink of water here. Is to really slow down the spread of disease, which I feel like we have done to allow our healthcare system time to plan so that we do have the necessary capacity when we start to see more cases. So I'll let Stefan talk more about the 4 to 6 weeks and things as it relates to the modeling. And then in terms of the dashboard to look at other things besides disease, but some of the impacts like suicide and abuse hotline, I'll certainly can bring that forward, to the folks that are working on that. That's not just from the health department. So I'll pass that along.
Anything further, Senator Jensen?
Thank you, Madam Chair. Ms. Erisman, when we look at the capacity that we have in the system today in regards to having 10,000 hospital beds available in Minnesota, 1,000 to 1,500 ICU beds, we have a number of med-surg beds that can be converted relatively rapidly. We're looking at a potential surge maximum of 3,000. Do you feel reassured that we are fairly well positioned, perhaps in the context of what you said earlier, where we need to have tests available and we need to make certain we have an adequate supply of PPE? Those two things, tests and PPE, within the PPE, especially the N95 masks and the gloves, because quite honestly, the ventilators, we're not even going to use nearly what we have. That's not as critical a piece. I think most people acknowledge that. And even the gowns, the idea of throwing away a full gown every time you go in and take a temperature of a patient, I think most facilities are now saying that's overkill. So what we really need in the PPE is we need the N95s, we need the gloves. In that context, are you feeling reassured that we're ready and that the capacity we built into our system, we're prepared to take care of the surge?
Ms. Erisman?
Thank you, Senator Benson and Senator Jensen. I'm not the person who's working day to day with some of the issues pertaining to supply and hospital beds. I'm dealing more on the epidemiology side related to the disease that we're seeing. I do know that, we've needed to have time because many of the orders that have been placed have taken quite a long time to come. But I know Lisa Timian from our legislative relations is participating, and I'll make sure that we get back to you on kind of an assessment of how we're feeling about our progress in that area.
Thank you, Ms. Erisman. And I think Senator Hayden, you have a follow-up question. Senator Hayden?
Yes. Well, thank you, Madam Chair, and thank you guys for having this committee. And sorry I came in a little late. I just wanted to, in the context of Senator Jensen's question, I want to make sure that we're doing some apples to apples work, if that's the way that I say it. So if we're going to start putting other things on the dashboard, it should be comparable to the same time last year or 5 years ago, so that, because people might, commit suicide now, or have domestic abuse, or whatever that it is that we're trying to measure to say what the outcomes are. So I guess I caution us, or make sure that we have it, some longitudinal data, so that we can compare this current crisis to what has happened in the past.
That seems fair. Thank you. Anything further? I'm not seeing other hands raised or other questions. Ms. Erisman, I want to thank you for your time. Very generous of you. I know you are nonstop, hours unimaginable every day. And so I want to thank you for making time to help us sort of get a really good view of some of the decisions we might have to make in front of us. So thank you.
Thank you. Thanks for having me.
Absolutely. Mr. Gildemeister, you have a presentation for us on the model, and I know a lot of us have had the opportunity to look at this. So if you have an abbreviated presentation, and I see you're sharing your screen, excellent, because then I don't have to learn to do that. Thank you. Mr. Gildemeister, please proceed. And members, again, I'm going to ask you to hold questions until the end. So thank you all very much for your patience.
Thank you, Senator Benson. Can you hear me?
Yes, I can.
Thank you. For the record, again, my name is Stefan Gildemeister. I direct the Health Economic program in the Department of Health. I'm the state health economist, and I'm not an epidemiologist, so I'm a little bit here outside of my area of expertise, but I am doing the best I can to represent the scholarship that's come out of the University of Minnesota, and that my team has supported. I do have the presentation that I gave to members on Monday, and since then I believe the governor's office has also forwarded answers to questions that were submitted and that we couldn't answer at the time. So hopefully your members have those. I think the hope was that I could do this in 15 minutes, and I will try to do my best and skip a little bit around the presentation. And I'm going to set myself a timer so that we have sufficient time. Feel free to cut me off, Senator, when you feel we've reached the max.
I'm going to try to let you get through the meat of the modeling so we can start asking some questions and I did take a look at what MDH sent today, and I appreciate them being so diligent in the follow-up to the Monday presentation. I hope members will have additional questions or unique questions. So please proceed.
Thank you, Senator. So I'll talk a little bit about data. I'll talk about the model and what has changed. I'll show you a few findings, maybe something new compared to last time. Not so much new findings, but rather new way of presenting them. And then I'll stand for questions. So you've asked me to talk about the model, but before I do that, I really wanted to recognize, as the governor has done and as the commissioner does, that there is a ton of data that comes from Dr. Erisman's team that really informs decisions of the administration. So you have your traditional public health data through syndromic surveillance, through tracking flu-like symptoms, looking at death records, investigating persons tested, a ton of material that is looked at by 100 staff or more. We certainly are looking at capacity in the system to ask the question that Senator Jensen asked. We look at other states, not so much to see whether we can brag or not, but to understand sort of what that curve might look like when it is changing from one moment to the next. As Dr. Erisman has said, there's a lot of science emerging every day, and we're looking at that as well, both through early publications from briefings from the CDC and in partnership with national modelers across the country. And yes, there's also the model. But before we get there, I just wanted to show you two graphs. Again, the point is just to give you some comparison data. I think all of this has to be taken with a not just a grain of salt, but with a rock of salt, to recognize that the data that we're harvesting from other states may not be as directly comparable and complete as our own data is. And the data on testing is really driving the extent to which our curve on cases per 100,000 people compares to other states. Sort of to take that into consideration here, we look sometimes at the scatter plot, where on the vertical axis on the left, we look at the degree of testing per 100,000 people. The higher you get, the more testing you do as a percent of the population. And then on the horizontal axis, we look at the rate of positive tests among those tests. So the farther you move out to the right, the more positive tests you're having in your population. So I wouldn't really compare us here, Minnesota, to Rhode Island or Massachusetts, where testing is much greater, but rather to this bubble out here. And I think what we're seeing from there is, at least at this point, Minnesota's rate of positive tests compared to states with the same level of testing seems to be on the low end. And that is one indication that our stay-at-home order has had some impact. So I'll talk about the model in a couple of ways. First of all, sort of the context and the concept underlying it. When we think about modeling diseases, there are different ways to approach it. What we have been doing with partnership with the University of Minnesota, and they really carry the science here, is to think about the disease as distinct steps in which the disease travels through the population. We need to understand who's susceptible, who's exposed, who becomes affected, and then who is recovered. And at each of the stage, there are probabilities that move individuals through these stages. So the so-called SEER model has been used effectively with other coronaviruses like SARS and MERS, and has been shown to be an effective tool. It accounts for the natural history of the disease, sort of this movement, right? And it recognizes that there's a biologic pattern to the disease that might differ very much from other diseases or other viruses in terms of the incubation period and the infection period. I don't envy all of Minnesotans who are looking at the evidence coming from all the models out there. There's a lot going on. It's hard for us to understand. I want to say this much, even models with the same kind of conceptual approach might produce related but different results. Differences between our model and the IHME model that's gotten a lot of publicity are incredibly substantial, and they relate to the period that we're looking at. They relate to the assumptions that are coming from China that are considered, and they also relate to sort of the conceptual approach to not really asking about how does the disease evolve, but rather what's the death curve looks like. And I can say more if there are questions. So essentially, the way modeling works is you have assumptions about key characteristics of the disease. And these are the ones that we are using here. They're coming all from the literature. They've been vetted and they've been used in this fashion by models across the country and across the globe. So latent period is an infectious period. And I should say, in red here are elements that have changed since the first round of modeling. The R0 is not an input in our model, rather it's a computed estimate that is a function of how the disease is transmitted in the context of the contacts that are available among people. We've reduced, based on US and European models, the length of stay in hospitals and the duration in ICUs. Most of that is really a function of mortality in these settings. When people die, they tend to die early in their stays, and that has been shown to reduce the length of stay. Two key factors about the virus is that, as Dr. Ehresmann said, there's a real relationship to age and underlying condition, and it increases the mortality when one is exposed to the virus but the mortality jumps even further for patients who require a machine to breathe when they don't have it. So essentially, doctors will tell you, 80% or above of patients who really need a ventilator, they can't get it, they will die. There are other considerations around what patients want at the point when they're very sick, but I don't have time to get into this here, and we've not been able to recognize that in the model. The other change in the model compared to earlier was that we built in the known higher ICU surge capacity that we expect to be available over the next few months. And these are machines with vents, and these are expected machines available to COVID patients. So to the extent that there are patients who require this level of care because of strokes or car accidents or other clinical concerns, the capacity is not considered here. They are, let me say this better. The total ICU bed capacity is closer to 2,700. So we assume about 2,200 are available to COVID patients. So a couple of really important changes occurred since we've shared some early results. One, when we instructed the model in the first go around, there weren't actual deaths in Minnesota, so the model was entirely built on estimates. Now, unfortunately, we have deaths in Minnesota, so we can fit the model to the experience on the ground. That makes it more consistent with what we're seeing. We've updated a number of parameter estimates based on literature coming online from Europe and from Seattle. Until recently, all the evidence really came from studies out of China done by European and Chinese scientists. And the things that have changed really are we are learning that there are more asymptomatic patients, meaning the estimates of hospitalizations are lower than we used to assume. We have observed, particularly from New York and Seattle, that the disease appears to be more transmissible. So we have a higher R naught that is calculated in the model and expect faster spread and a quicker time to peak in the model. And then, as I said, lower length of stay for the hospital and in the ICU. We're looking on an ongoing basis at the conditions that the literature identifies putting patients at a greatest risk for bad outcomes or requiring hospital care. And then lastly, and I have some new data visualizations to show, we've been sort of, as a research team, stressed out by point estimates being presented. There is a large degree of uncertainty around any model, and we wanted to make sure users of these data understood that. So a couple of takeaways from this latest round of modeling, and I should say, while I'm speaking to you, the scientists at the university are working on the next round, updating the model, looking at evidence and looking for ways to extend it as well. We are observing a modest shortening of time to peak infection and peak capacity, but we're also estimating fewer deaths, again, because of the changes in the parameters that I told you about. A couple of takeaways from this modeling. And I should say again, modeling is not really about forecasting precise outcomes. Instead, it is to give us a general directions and give us a chance to appreciate how alternative tools might produce marginal differences in terms of the outcomes. So one has to understand what the model can do and cannot do. What we've seen from the modeling is there are two primary factors really driving lower mortality. One is the increased ICU capacity we've brought online, and secondly, the expectations that vulnerable adhere to the ask to stay at home. And the logic is the following: with more ICU capacity meeting the demand for ICU care, we have fewer patients needing a machine to breathe who don't get it and who will then die. But secondly, succeeding in letting the virus not circulate among people most likely to require healthcare will reduce the demand on healthcare. So fairly straightforward stuff, I think. We have also found the stay-at-home order, a stay-at-home order, and our model is not entirely consistent with what the governor put in place. But any extended stay-at-home order would extend the peak to time, so it would buy us more time to work with healthcare industries. And secondly, in addition or alternatives to a stay-at-home order, when they're really implemented over a long period of time, can also further reduce ICU demand and mortality. So I have a couple of scenarios. I'll skip that chart because it takes me too long to explain. Suffice it to say, we've modeled a number of scenarios with alternatives that with alternative ways of mitigation that I'll try to walk you through as we're looking at this. And I'll start right here. Scenario one was essentially the no mitigation scenario. The change here was we're seeing a quicker time to peak and lower mortality, and that's also true for scenario two. The new scenarios are 3 and 4. I'll focus on 3 and 4 really because 3 was estimating the impact of just asking the most vulnerable, and in this case, mostly the elderly population, to stay at home and not expose themselves to the virus. And that really dramatically reduced the estimated mortality, but not anywhere close to 0. And then scenario 4 sort of is a variant where it's not just where the stay-at-home order is not just focused on the elderly, but really on all. And the marginal differences here is that you're buying more time. And then 3.1 and 3.2 are sort of variants on 3. Visually, I wanted to demonstrate this by saying this is the scenario where at the end of May 1, the stay-at-home order would have stopped. This is the peak we would have expected sometime around June 8. The scenario 3, focusing on asking the vulnerable to stay out of harm's way, would have reduced the peak stay-at-home order for all, which would have much more dramatically reduced the transmission of the virus in all of the population, pushes the timeline further out into the middle of July. So I'll skip these scenarios other than to say they each have a marginal impact on the height of the ICU demand, and this is what I'm showing you here, but also when it occurs. In red here, you are seeing the variation or the uncertainty associated with these estimates. Number of weeks, thousands of ICU beds, and tens of thousands of potential people dying. It's really hard to consume, so we wanted to show you this in a different scenario. So we were looking here at scenario 2 and scenario 4. And what we've done, so one thing to note is the model is not a stochastic model, so there isn't error estimation built into it. Rather, what we have done is built a series of probabilistic distributions around the parameter assumptions. So we vary them marginally along within a range of acceptable parameters in the literature and see what outcomes we get. And here we're looking at the distribution of the peak for scenario 2 and scenario 4, 1,000 iterations, and see sort of the earliest that the curve could emerge and how high and how low are plausible outcomes for each of the scenarios. The base curve is the line that we have drawn. I also wanted to show you a different story, or rather different presentation, focusing on mortality estimates. Again, here are the estimates that produce about 20,000 deaths. I'm sorry, 40,000 deaths here and 20,000 to 20,000 deaths under scenario 4. The deaths are not all occurring at the peak, of course. They are occurring right now, for example. They are highest at the peak, at about 17 or 1800 expected patients for scenario 2, or about 1,000 patients for scenario 4, and they continue even after the numbers are declining. Here, what we're showing you is not just the variability around the peak, but each curve represents a plausible set of parameter estimates sampled, 100 cases sampled. So I want to close really by telling you what's coming next, and then giving you a chance to respond, to ask questions. Models are only as good as the inputs, and the inputs are really emerging every day. So we expect to continue to update the model with new data, and to continue to fit Minnesota deaths to the analysis. There's been a lot of discussion about, even on this call, about what comes in the future in terms of mitigation, and some in the national world are talking about on-off scenarios. People are talking about Singapore seeing reemergence of the virus. So we're thinking about ways to program that. We want to better understand asymptomatic infections to the extent that data are available, and then really need to evaluate the robustness of peak ICU demand based on data and the literature that we have available. It's been a lot of ask about how does the disease represent differently in a temporal fashion, but also in terms of peak over all of Minnesota, given that there are different contacts. It's a real important question. We haven't gotten the data to illustrate that, but we are exploring this question over the next few weeks. Some in the community have been really frustrated with how slowly we've been releasing information. I apologize for that. All I can tell you is that the team has been working extremely hard across MDH and at the university, and we've been trying to put one foot in front of the other. On the 10th, we've released some really geeky technical documentation and an FAQ plus an infographic. We are updating this based on a few dozen questions that we've received from across the state about technical detail, and we hope to do that by the end of the week, although that's already tomorrow, soon. And then we expect to release an interface for the model and the underlying code sometime in April. And I'll pause here other than to show you the beginning of a long list of limitations that users should be aware of as you consume output from the model.
Thank you, Mr. Gildemeister. And I know there are a number of different scenarios that you modeled. And the one that is closest to what I think the governor's doing is scenario 4. And so one of the challenges that we've been having over these past several weeks is, for example, the differences between scenario 3.2 and scenario 4. One might have less of an economic impact than the other, but one pushes the curve a little further, but they have apparently the same ICU demand and very similar mortalities. So could you help me understand, are there nuances we're not seeing as to why scenario 4 would have a better outcome than scenario 3.2? Because just my reading of the model is they look very similar in their outcomes, but one puts a lot less stress on the broader population. So maybe there's something I'm missing. Help me out.
Thank you, Senator. Thank you for asking me to present and for a good question. I'll go back to making 2 points. What you get with me is sort of the data perspective, and the decision making is outside of my area of expertise. So if it's okay, I would ask that you raise that question with the governor's office or with the commissioner. The other point I would say, my understanding is clearly that the model gives us some results with some degree of uncertainty, but we are also hearing from others across the country sort of what the dangers are of leaving too early, and what sort of some of the criteria are that are being emerging about coming off the brakes slowly and intentionally. So I can only imagine that those were considerations that came into play here. But to your particular questions, I agree. You can get at least the same point estimates from a different mix of scenarios. These are all hypothetical, I want to say, because we don't know what comes after May 4 or after May 8. They are artificial in the sense that the May 4th decision or the next decision is likely a function of how the disease moves through the population, how satisfied we are with our testing regimen, etc. So it's a complex set of optimization issues that I think we're all facing here.
Members, just to help you orient a little bit, slides 11 and slide 13, I found very informative to sort of play off of one another as I was walking through economic scenarios. But I've got quite a list developing here, so I'm sorry for delaying things. I have Senator Nelson and then Senator Kiffmeyer, and we can take a little extra time and go up until 5. So Senator Nelson.
I would boil it. What I would do is put a
Mute there. Thank you, Madam Chair. Just a brief comment for Mr. Gildemeister. I appreciated the fact that we saw data in a per capita reference on a number of your earlier slides. I think that really helps, at least it helps me get a better sense of what is happening. And I've often been disappointed when I hear news reports and such that don't put that per capita piece in there, saying the US has more deaths than any other country, for example. That's it's not an accurate picture if you don't put some per capita parameters around that. And so with that in mind, I noticed on our state dashboard, it's not per capita. So in my mind, it'd be very helpful if when we look at those counties, instead of looking at the number of cases, if we were able to look at per capita. For example, Martin County and Hennepin County have two very, very different populations, but it could be, we don't know, it could be that their per capita amount is the same. I can't tell from those numbers. So that's just a suggestion going forward, is to get some per capita numbers on there. And then I was most intrigued by your comment as we're looking at, how do we go from here? And I think the first thing is Minnesotans should pat themselves on the back, actually, for moving that curve out, for flattening that curve. We did that. Minnesotans did that. And now we have to look at, well, what's phase 2 and how do we get to that? And I noticed your comment regarding our testing regimen. Where are we on our testing regimen? Because when you mentioned about scenario 4, it was like to move the peak out further. And my question was, why would we want to move the peak out further? Do we not now have adequate, hospital beds? Do we have adequate ICU? Do we have adequate PPE? I'm understanding we don't have that. But is it just because we're not ready, or are we ready? Do we have our systems in place other than the testing? And then I want you to circle back to that testing and how that's going to impact which of these models might be best going forward.
So Mr. Gildemeister, we don't have much time. Maybe you just want to pick one, and then you and Senator Nelson can have a more direct follow-up, because I do want to be respectful of other folks who've gotten in line. So the testing, Senator Nelson? Okay.
Yes. Thank you, Senator Benson and Senator Nelson. I have seen a really pretty per capita slide that my team members did. So I'll pass those on to the state dashboard folks. I think you're right. Testing, I can't, there's a lot of swim lanes, and I can't speak to the testing swim lane. What I can tell you in the context of the model is the question about phase 2 and about how testing is paired up with isolation of suspected or likely patients, likely exposed patients, is another instrumentarium in our very limited tool set. So I think both administratively, the governor's office is working on a work group, as Chris Erisman said, but also this is something that we can reflect in the modeling if we can get the data to sort of illustrate how testing and targeted isolation can be paired with a sort of comeback strategy. But I also wanted to recognize what you said earlier, the curve that you're seeing here, the smooth, the drop after the very early peak here is what Minnesotans have earned the healthcare community. So that is the time that we've bought with tears as our kids are trying to learn at home and we are trying to work. So being isolated is what has changed the curve in Minnesota at this point.
Thank you. Senator Kiffmeyer?
Thank you, Madam Chair. Thank you, Mr. Gildemeister. Fascinating discussion for those of us who actually enjoy these kinds of numbers, I guess. Question I have for you, if you have used this before for SARS and for MERS, could we get the estimated to actual so we can see, since you're saying this is a similar model that you've used before, how did this work? And by this time you should have an estimate to the actual. I hear you use the word China sometimes. I'm not confident of using them because I'm not sure that they've been honest with us. The other thing is that Minnesotans have been doing some of their own charts. A couple of them have sent them to me. I will send them on to you as well because I'd love to have you take a look at them. And I had asked you before on another phone call, was in this modeling, did you factor in the fact of some of the hydroxychloroquine medications that are developing some success and that you could maybe factor in if those were, what might that look like? Or as we're finding out now, the vents, this particular virus doesn't seem to act in the same way as ARDS in the past using the PEAK protocol. So considering that, have you done any modeling or factoring in those two items in your current scenarios?
Mr. Gildemeister.
Madam Chair, Senator Kiffmeyer, so 3 good questions. This model is actually built from the ground up for Minnesota for the epidemic in front of us, but the concept has been used for SARS and for MERS, and we'll look for papers that provide the information that you asked about. China, all I can say is we don't know, but there is some really important scholarship that all of us have been relying on to even get a picture of what this might look like. Some of the data looks different now that we're seeing the epidemics in Europe and in Seattle. Some of it is structural. I hope we're learning that we've had halfway decent data. Speaking about data, so I'm looking forward to the charts from Minnesotans. Although, as I said, since Friday last week, I've received personally dozens of emails with charts and other questions and information. So I might have those already, but I would love to take a look. To the question about treatments, I will agree with what Dr. Erisman has said. Best practice here is to use available data on how treatments affect, the SEIR, the exposure, the infection, the recovery, and that data, to my knowledge, doesn't exist. Also, the conditions haven't the treatments haven't really been proved by the FDA, so I don't know to what extent actual data is being collected on the treatments. But for any treatment that will come with data, that is something that we want to build into the model, including vaccinations, by the way. And then, yeah, I'll pause there.
Madam Chair, I just want to make a last comment.
Yes.
Thank you very much, Madam Chair. The big thing, Mr. Gildemeister, that I hear from Minnesotans over and over and over again is this number of 22,000, the huge number of hospitalization ICU beds. Their kind of common sense type thing says they look at what's been happening for the last 4 or 5 weeks, other states and everything else, and they're saying, how can this be in Minnesota when we're doing one of the best states, one of the lowest, and yet we can have numbers that you might expect to see in the greatest hotspots in Italy. That just doesn't compute to them. They just doesn't see the sense of that connection.
Mr. Gildemeister.
Senator Benson, Senator Kiffmeyer, I appreciate that question, and I've had it. You know, my own colleagues in the health department are asking those questions. Here's how I would respond to it. All the data that we're seeing across America seem physical isolation. What we are modeling is what happens when that isolation is removed and when we're starting to circulate among each other, when we're getting back to the community, when we're going out, when we're having more contact. And sort of the way the virus works simply is that it's very transmissible and it has a high rate of fatality as far as we are understanding. So the reason things are so good in Minnesota right now appear to be because we have not allowed the virus to circulate. As Senator Benson says, that also has stopped us from really acquiring herd immunity. That is absolutely the case. But during this time, we have been able to gain infrastructure capabilities that we didn't have in January or in February or March. I hope these estimates are pessimistic, but my fear is the way we understand the virus, how it's transmitted, how rapidly it transmits, and what impact it has on people, is that these numbers are realistic within the bounds of uncertainty. But I agree with you; these are large numbers. They're frightening. I hope in a 6 months you can criticize me for having been too pessimistic. I will gladly take that.
Anything further, Senator Kiffmeyer? And then I do have Senator Abler. Then
Nope, that's good. Thank you.
Thank you. Senator Abler.
Thank you. I think I'm just on audio.
No, you're on video.
Better smile nice. Anyway, welcome to, I'm in downtown Anoka. Look at all the construction on the street out here. Mr. Gildemeister, I asked Ms. Erzman a question. I don't know if you heard that one. She was able to explain that there is some kind of a COVID risk, index of some sort. And so since you're the data guy, can you explain to me how, for instance, automated car washes being closed would affect your modeling and the COVID risk factor of that particular activity?
Mr. Gildemeister?
Madam Chair, Senator Abler, I cannot speak to the car wash question, but I would say I think your common sense holds there again. What we worry about is transmission from actual contacts. And contacts in this case means where people can pass the virus on. Unless there's somebody sitting in your car who's exposed, I can't see how the car wash would be a risk area. So I think, like Chris, I will pass your comment on to others who have some insight into that.
I appreciate just one more comment, and I know you're running out of time. And so there's a number of places that are open that have been allowed to handle their own sanitation and infection control, so on. Places like Walmart, for instance. And I would consider those to be a relatively high-risk place, having actually gone there. And I'm not sure I'd bring my 85-year-old, actually she's 93-year-old mother to that place. And so the question that seems to occur to me, there's many places that have a far lower risk in, like we talked about, 1 and 2 person operations on Main Street, for instance, and side streets and so on, that provide extremely low risk and hardly any transmission, and they can easily accommodate that. And so when I say that, people say, well, you're no epidemiologist. How could you possibly know? So I'd like to have you comment what you think about that.
Mr. Gildemeister?
Madam Chair, Senator Abler, I'm only an economist. So I'm of no help in this. But again, I would say the magic is going to be to figure out ways to slowly bring us back and see what happens. And do that sort of within safe parameters. And as Dr. Aresman has said, there's a work group in the governor's office that looks at businesses, industries, practices, guidelines. I don't go to those big stores either. I've gone to my local co-op, and there are yellow lines that tell me exactly what the distance is, and I might wear a mask or a bandana. So I think we're going to be spending a lot of time figuring this out and learning about it, and hopefully the data will bear out that we're doing a good job.
And thank you. And so maybe if you don't mind bringing those back to your meetings, and I guess the summary of your presentation is do the math, Mr. Gildemeister. Thank you very much. I appreciate it.
Thank you. And members, I want to thank you very much. Mr. Gildemeister, I've been through this presentation a couple of times, and some of the requested updates are included. I had such a list of questions, but we had a good hearing, and I'm not going to burden folks with any more time today. I would like to see going forward more data from countries whose perhaps reporting and medical standards reflect ours more than China does. So I would hope that the model would continually improve and reflect that. As I went through the detailed summary that you had online, I saw a lot of references to core factors being from China, and I'm hoping that those are getting updated to be more reflective of, as I said, medical systems that operate like ours. One of the things that you and I talked about a week ago, actually, was that you model some of these scenarios out to 0 case days as an indication that the epidemic is over. I hope that we can have some visibility as to when each of these scenarios gets to 0 case days, because that gives us another relative reference. There are some folks who really distrust this model, but if you support this model or believe it's a good standard, even looking at things relative to one another would be an important reference point. So the number of days to 0 cases, I think, would be important and transparent in this model. I applaud Senator Kiffmeyer raising the changes in testing capacity. I hope that as we get tests approved, we start seeing that appear in this model. So again, I want to thank you, Mr. Gildemeister. You have given us a lot of time on this model over the course of the last weeks. As you get updates, I'd appreciate being included on those, and we'll see if we can find time for the folks on this committee. As we have to make difficult decisions, this model is going to play a part in those decisions, or other models if we continue finding other resources that perhaps meet Minnesotans' needs. And with that, members, I want to thank Mr. Gildemeister, Ms. Aresman, all of you for your attention. There are some other things going on. There was a legislative auditor's report. Let's see if I can actually do this, maybe not. The Minnesota Eligibility Technology System is something that we should discuss. So the legislative auditor issued that report. We're looking at next week to move language that is serology testing. Senator Nelson dropped a bill. I've been working with the governor's office and shown some language to the House so that we could actually start priming the pump and get moving without waiting for the feds to come in. And then something else, members, a year from right now, most of us probably think we're going to be here. A year from right now, I am fairly certain we're going to be facing a significant budget deficit, and we're going to have to make really hard decisions. And so as we talk about getting the economy moving again, and we talk about our hospitals being ready so we can open them so they stop losing money and don't have to lay off doctors and nurses, I'm looking ahead to the kinds of decisions that we'll have to make. And my rush to open things isn't because of some public pressure. I hope that we can all approach this with the balance of making sure our hospitals are ready and our healthcare workers have what they need, but also the understanding that we are going to face budget deficit starting with an update that's probably coming here in May and then forecast in November. And we are going to have to make difficult decisions such as those that were made in 2011. Senator Abler, very familiar with those decisions. And so my desire to open up the economy isn't just about economics. It's about bridges for businesses to keep employing people. It's about shaving off some of the damage that that deficit is going to cause. And so, again, I hope that we use the information we have today to make decisions that makes it easier to open up our economy while providing our healthcare workers with what they need. People have likened this to war. That was the theme on the floor today. I look at us as being in May of 1942. The logistics for the D-Day invasion hadn't even started, and they were just getting an understanding of what it was going to take. We're going to do all of that in a very short period of time, and I'm glad to be on your team. Thank you for your attention. Thank you for how interested you are in learning about this. And with that, members, I'm going to adjourn this meeting, and Bailey will send out announcements when our next meeting is ready. I thank you all for your attention. Have a good evening.